This is our fourth leadership conference that we have been able to hold. We had to take a pause last year due to COVID and some of the restrictions, and we have gone forward with the virtual conference so we can continue connecting with our network, our community all over the country. We have folks joining us internationally, which is very exciting. And during our two-day lineup, we have pretty amazing content. We have updates from both NIDA and NIAAA, along with a drug threat assessment from the DEA. We are covering topics such as children impacted by parental substance use disorder and new innovations to improve services and outcomes for the most vulnerable in this epidemic. We also have a panel later today to dig into new data around a APF program to address stigma and help families in crisis called Encompass. And tomorrow we have our virtual Hill Day, which we're very excited about. We are bringing in Congressman David Trone to give us an update on two of our top 7 priorities on Capitol Hill this year, and actually doing some virtual advocacy work all together, which is great. We're also featuring our Pillar of Excellence Award winners over the next 2 days. One of the, I think, sort of highlights of our conference every year is to be able to raise up and celebrate those on the ground across the whole continuum of services who are doing amazing work and are innovators. So we'll be hearing from folks from the research community to treatment to recovery supports and prevention, which is really, really exciting. So at that, I am going to hand it over to our chairman of the board, District Attorney Jonathan Blodgett, for some welcoming remarks.
Good morning, everybody, and thank you so much for being here today. Jess has given us a great overview of what we'll have the next 2 days, and I want to just reassure everybody who's on today that APF has been working extremely hard with a very talented executive director and Jessica and staff to make sure that we provide and give to you the most important and up-to-date information on this terrible scourge that we continue to fight throughout our country and impacts our families so much. I'm so proud to be able to be part of this organization with our board members and the staff to bring this information to you and to let you know that we always do our best to adapt to what's happening, to pivot when necessary, and to keep our commitment strong to all of you. So with those brief comments, thank you so much, and I'm really looking forward to the next 2 days. Thank you.
Thank you, DA Blodgett. I also want to recognize Judge Rancourt, who is on the board of directors for APF, who's joined us this morning. Judge Rancourt brings so much experience from the judicial branch, and we met through the NIDA Council, so his input and expertise that he lends to so many of us is so appreciated. I also want to give a shout out to the amazing team here at APF that has made this conference possible. Eric Arndt has been the project lead and manager of the conference. So Eric, thank you so much for all of your hard work. I also want to thank Haley Tenney, who has spent countless hours helping out with conference prep as well. And we also have Sean Rogers, Braden Kelly, Kayla Zawazlak, Liliana Coronado, and other staff members that I'll recognize later today, that we really couldn't do this work without you. So thank you so much. Our first speaker this morning is I think such an important voice nationally and has done so much work in this space. General Barry McCaffrey, who, as you all know, has such a distinguished public service career, but also served as drug czar under President Clinton, where I got to know him originally. His leadership and vision and sort of input on how we can make sure we bring people to the table, that we keep advancing our response to addiction in new ways every year. And his advice and counsel to us at Addiction Policy Forum has always been so important. And we're so grateful that you could join us this morning to give remarks and stay with us for a bit so we could do Q&A with our network. As a quick overview, just for all of our speakers that are here today, our board members and General McCaffrey, Our participants and those that are part of the Addiction Policy Forum Network are very diverse. It's not just folks in the US, but internationally, but it's also patients, families, researchers, practitioners, criminal justice professionals, to those in recovery and treatment providers. It's such a wide range. And the input and the feedback that we get from our network, I think, really makes us able to respond quickly to new needs and challenges on the ground. They give us our sort of drive and so much input and excitement to make sure we can come together and use our voices collectively to drive change, to work to implement evidence-based practice and treatment and recovery worldwide. So we're really grateful everyone's joined us today. And I'm very excited that I get to introduce and welcome General McCaffrey as our first speaker at the conference.
Well, good, Jess, and hopefully this technology is working. You know, at the last minute, I'm no longer in Seattle at a little home studio. I'm in a hotel room and here in Crystal City with a MacBook propped up on a Kleenex box, so I won't make any sudden moves. And Eric, thanks to you and the whole staff at APF for bringing us all together and setting this up so nicely. It's just astonishing. 850 some odd participants. Just astonishing network of patients, families, experts, leaders in the field. It's such an important organization. And just without embarrassing you, I got to tell all the participants that I've been a lifelong admirer of this remarkable leader. Jess has done such an incredible job to bring people together. Her life story is so moving, so impressive. I used to have lunch with her once a year when I left the government drug policy director. I tell my wife I'd be in tears every time we had lunch because of her compassion and identity with the families and those who are suffering from drug abuse, particularly the opioids. My God, you know, it's just astonishing. So again, Jess, thanks for your leadership and your friendship over the years. I'm going to miss Dr. Nora Volkow, who I deeply admire. I think that budget's like $900 million a year. These are the people with muscle in science, an NIH institute. You know, we simply can't wing it. A lot of drug treatment programs, admittedly, are an art form, you know, aromatherapy and other things that may not have an objective connection to getting in recovery. But without the science of it, without you know, Dr. Volkow and her incredible team's long-term research, which then Jess puts to play in real life, we'd have great problems. I know she got Dr. George Koob speaking, NIAAA. You can't talk drug abuse unless you recognize alcohol. You know, at the end of the day, if you talk to a cop with 20 years on the force and say, what's the biggest problems you run into? To some extent, you know, it's either methamphetamines or alcohol. That's where the belligerence, the illogical behavior, the, you know, rapes and despicable behavior comes in when people are drunk. I remember one data point, like 90% of the burglaries are carried out by somebody who's been drinking in the last hour. So I'm glad he's taken part. And Dr. Sean Fearns, DEA, I haven't met Sean before, but I'll tell you that DEA plays a vital role. You know, at the end of the day, if we didn't have these incredibly brave, classically trained networks of federal agents, we would be overwhelmed. And we know that the more drugs are available and the cheaper they are, and the younger you can find them, the bigger the problem. So the DEAs and the FBI now, having pivoted mostly to counterterrorism and local law enforcement being really overwhelmed with a variety of issues. Thank God for the DEA and what they do. And they're dealing with the most dangerous groups on the face of the earth. You know, not only are they incredibly violent criminal organizations, but they're backed up by sophisticated technology. They buy legal representation. They buy public relation firms. They buy block voting behavior in national legislatures in some of the drug producing countries. So it's quite a challenge, and I've been very proud to work with them over the years. You know, let me sort of set the stage, and we'll very briefly, we'll hopefully have a chance for me to listen to your own viewpoints and respond to your own interests. But I think the first thing you got to say when you talk about the drug issue, in particular the opioids, is the scale of the disaster engulfing the country. You know, we've been using the term twin pandemics, and one of them we follow pretty closely. We just had a bellwether, I think yesterday, of 750,000 dead plus US from COVID. And that undercounts the total completely. If you just look at the gross early death figures, it's much higher than that. The upshot of it is, as all of us know, is its impact on the economy, American political life, national security has been atrocious. But in particular, to try and deal with this terrible principal healthcare challenge America faces, which is the use and abuse of illegal drugs and alcohol. And so, you know, I was listening, Jess, to Dr. Volkow on one of her seminars a week or two ago. She noted to my astonishment, I was using an old figure, that in the previous 12 months, starting in March, there were 99,000 dead from overdose. I mean, it's just astonishing. The year prior, it had been 72,000 dead, for God's sakes. And that was a dramatic jump up from, I think, the year prior to that, probably in the 50,000s. This is a massive loss of life. This is a higher loss of life than World War II killed in action per year. It's engulfed us. Even worse, I'm still engaged in various ways with the drug issue. It closed down almost all of our systems. Obviously, it closed down the criminal justice system, not just in drug-related offenses, but almost across the board there for a long time. They're just now trying to understand. John Blodgett, our distinguished chairman, understands only too well what happened in the criminal justice system. But a lot of these programs don't work without some involvement of criminal justice. And it ended, which also ended our treatment programs and monitoring them. And how do you manage drug testing systems? And how do you ensure that your client case management group is actually getting to treatment programs, which may also be trying to work on Zoom or non-existent. So the twin pandemics have been simply an incredible punch in the face. In the background are all the other drug issues. And, you know, one of them that just popped to the surface, deaths from alcohol abuse. And I'll bet this is a low number, now exceeded 95,000. And cigarette use has now increased again. Of course, that's a long-term health threat, but almost every year it's over 400,000 dead from cigarettes. That's a huge problem. It's a principal problem. When you start unraveling almost anything you don't like about America, you're going to find drug abuse at the heart and soul of it. You know, whether it's beating up your spouse, whether it's stealing from your employer, whether it's dying in the basement of your mom's house from a fentanyl overdose, that's frequently at the heart of it. I guess the other thing I would suggest that we need to talk about it. There's a new study, which I know Jess has seen out of Harvard, on social determinants of health. And so we already knew this instinctively, people that deal with the issue, that, yeah, drugs affects all of us equally. If you're a dentist in Miami or a Honduran illegal immigrant in Los Angeles, the human body and its relationship to these 12 principal psychoactive substances responds remarkably the same way. However, if you don't have a family that's engaged, if you don't have money for lawyers, if you can't pay cash on the barrelhead for treatment programs, you're in even greater trouble. So poverty, homelessness, social stigma, you know, diphtheria, cancer don't have stigmas attached to them, which prevents people from engaging in science-based treatment programs. So we have to take into account then larger issues on how do we deal with these social determinants of health. I live principally in Seattle. We have 11,000 homeless people in King County living on the streets. It's worse conditions, bar none, than I faced in combat in terms of freezing rain, just astonishing. And there's no way to reliably deliver healthcare services or to engage the population that's suffering. Another point that always has to be included. Everybody, I remember years ago, Dr. Rosenthal up in New York City telling me that everyone dealing with drug abuse wants to find a magic pill. If only there was a magic pill. Would buprenorphine be the magic pill? We could just dispense it widely with naloxone. Will the problem go away with some pharmaceutical intervention? The answer is no. In every case, there's a package of services, and that takes money. That takes organizational skill. That you have to attract some 25-year-old young woman who's got a college degree from George Washington University to come into the field and stay with us. So you got to deliver a package. You can't just hire two 21-year-olds in a van to drive around town dispensing free needles and a comic book on how to not go HIV positive. You got to have a package. One aspect of that package is coercion. Coercion might mean just the warm, loving disapproval of your mother, or equally, it may be one of our 3,000 drug courts where you have some judge who's the first person that the person in front of him has met in years, that both has authority and cares about it. The drug court system, you have to have some coercive element also. Mostly that isn't how you get in recovery, but it has to be one aspect of the program. I mentioned buprenorphine, medical assisted treatment, MAT. We've seen a growing family of remarkable interventions, and I'm not going to mention the organization. I was at a board meeting with 30 people in the country who know about this issue, and our chairman made a big point that he didn't believe in MAT except for brief periods of time, because we didn't want to substitute one addiction for another. Holy crow. I mean, the reason we spend these hundreds of millions of dollars on science is to get tools that can help us intervene. It's just one part of the package. It can't be the only part. And by the way, I'd be remiss to not remind all of us that the single most important organization, bar none, dealing with drug and alcohol addiction is AA and NA. So it's got to be part of the package. Most discouraging thing in the world to me is go to a treatment center. One of them I'm thinking of in Florida, two handsome young guys taking me around, 30 somethings. Tell me about your background. Both of them had been in recovery over 5 years and relapsed, and primarily because they stopped going to AA or NA. So you need a package, and that has to include, where appropriate, pharmaceutical interventions that are coming out of science used in an appropriate way. The great debate, harm reduction versus maintenance and sobriety. It used to be we were hard over, and when I heard harm reduction, I'd start shouting and waving my little fist and say we didn't do that, because in too many cases it was a cop-out. It takes hard work, it takes resources, it takes organizations to deal with successful treatment. Now, having said that, clearly there is an argument on reducing both the trauma on an individual as well as the impact on the people around them. And somebody chronically abusing drugs is affecting not just their family, but their employers. In Seattle, our public parks are all gone. People are living in abject misery, defecating on sidewalks. Abuse of women is transparent in broad daylight. So you do have to do harm reduction. You got to keep people alive until sometimes people age out. I just had coffee with some 50-year-old mother and her adult son who's been a chronic opioid user most of his life. And I told her, look, the best thing you got going for you now as he gets older, many people who survive do sort of walk away from that issue. Not sure what the science of it is, but that's clearly what happens. Well, I think the final brief comment I'd make is Veterans Day is coming up next Thursday. I'll be down talking at the Vietnam Memorial as a speaker. You know, the 3.5 million of us served in Vietnam, another 3 million served in Iraq and Afghanistan. For a variety, and by the way, the biggest challenge in VA right now is the Vietnam generation. It's not the younger kids. The impact of age combined with some elements of emotional trauma combined with alcohol abuse in particular, but also drugs is remarkable. But our veterans are actually in trouble. Not most of them. Most of them are healthy young women and men. You know, we recruit in the armed forces from the top 25% of American males and the top 15% of American females. And they're all volunteers and they're all high school graduates and they don't have felony arrests. And, you know, so they're a great group of young people. It's the best military we ever had. 60,000 killed and wounded in the war on terror. 1 out of 10 are people behind bars are veterans. 107,000 veterans are in federal or state prison systems. It's simply unbelievable. 1 out of 3 veterans at some point will be arrested. There's 18 million of us as veterans. We got to engage that population. And it's not just money either. VA is actually a remarkably good, effective organizations in large part, dedicated people over there. So it's not just money. In some cases, it's better organizational linkages, particularly for the Guard and Reserve, who are not, you know, returning from a combat tour in Iraq and going back to Fort Bragg or Camp Pendleton. But we do have a problem with our veterans. So look, on that note, Jess, thanks again for allowing me to join you this morning. And if we've got the time, I'd be glad to respond to questions until you tell me to go away.
Thank you, General McCaffrey. Yes, we'd love to open it up for questions from our participants. And also if there's questions from our other panelists, DA Blodgett, Dr. Koob, Judge Rancourt, if you have any comments or questions, or if you want to jump in on any of these items, we'd love to hear from you as well. I have just a couple items. You've covered so much ground, General McCaffrey, and a couple things just really jump out. And I think also are really reinforced by some of the work that we are doing at APF. You know, you started off by talking about these twin kind of epidemics, or sort of the like head-on collision between COVID and the opioid epidemic, or synthetic opioids with fentanyl. 99,000 overdose fatalities in a 12-month period, over a 30% increase from the previous year. We're seeing increase in suicide rates and suicidal ideation, mental health distress among so many Americans. And for our population that is struggling with a substance use disorder, either an active substance use disorder in treatment or in recovery, really early on into the pandemic, right after the shutdown, we did a small research project, a survey of our community, just to understand what was happening. Because within 4 hours of that shutdown, we were hearing from our folks that they were in distress. Isolation, anxiety, these are all things that are not helpful for recovery or for any of us, really. And then there were so much disruptions in services and confusion and difficulty for people to access what they need. You mentioned AA and NA. Our mutual aid support groups, 12-step, there's so many brands of them now. I think there's over 30 different types of support groups you can access. They are the foundation of the recovery support and the social system that supports individuals in recovery in our country. And lack of access to that, moving to Zoom, though they worked so hard to transition, that effect was felt so acutely. From our patient outreach, we found that 2 out of 3 had negative disruptions in their treatment services. Our network reported that there was a 20% increase in substance use, and that even individuals who had a number of years in stable recovery were really struggling because of those disruptions. And one actual quote that we received, because we like to put quotes in from our patients and families, said that, you know, my services, my meetings are closed down, but weed shops and liquor stores are still open. Our society is so twisted. So my question to General McCaffrey, to our board members who've tuned in, you know, worst case scenario, knock on wood, it doesn't happen. But if we hit another sort of variant surge or shutdowns or another public health crisis like COVID, can we do a better job of communicating to public health and policymakers that addiction and recovery services are indeed essential? And when we don't recognize them as essential, we see things like this huge increase in overdose deaths.
Yeah, boy, there's a lot there to what you had to say. You know, I remember a couple of years back, you started to see the healthcare community talk about loneliness as a factor in recovery, not from drug and alcohol use, but just in general from illness. And that may be a significant factor behind the nationwide steady increase in suicide rates over the last 20 years. It's just astonishing. I always focus on military suicides, which are now barely above the civilian suicide rates for the same age group. When you back off and look at 20, 30-year span, it's gone up all across the country remarkably. There's a great book, somebody I really admire, Sebastian Junger, an author, a documentary producer. He's got a book called Tribe, a very short one. And he was looking at PTSD, and I'm not sure if our mutual friend, Dr. Sally Sattel, would agree with this, but he said, look, a lot of PTSD is a 22-year-old soldier in combat with the Ranger Regiment or a Marine Battalion landing team, danger, commitment, care for each other, deep bonds of camaraderie. They come home and suddenly they're back in Duluth and nobody around them is engaged. And that's when they get involved with drugs, alcohol, unemployment, homelessness, etc. And I think there's a great deal of truth to it. By the way, I'm on a webinar this afternoon on Veterans Treatment Court with Judge Rancourt, one of our mutual friends, Dr. Robert Russell, Buffalo, New York, who really started the 350 some odd veterans treatment courts we have. But I guess we got to hope, look, President Biden Senator Biden actually wrote the enabling legislation for ONDCP, National Drug Policy Leadership. He cares about the issue deeply. He understands it. He's got to empower, which didn't happen with the last administration, for that matter, the last couple of them. He's got to empower the people in ONDCP to have a all of government approach to this and to recognize, I mean, how can you ignore numbers like 99,000 dead? It's just astonishing. I think the criminal justice system, and of course, John Blodgett knows more about this. My wife was summoned for jury duty in a federal court trial, and the amount of resources that were tied up and to make that happen. The jury was going to be in one courtroom, the judge in another, the witnesses in a third, connected by Zoom. So the process went to 4% of what they could move through the system beforehand, and even that was grudgingly. And so we saw that happen in every other program we do. Case management of the pick a number you believe. There's 18 million people struggling minimum with polydrug abuse of some form or another, and it's killing them. It's just a disaster in healthcare and criminal justice. So, Jess, your point is well taken. All of us involved in this issue have to engage, and let's hope that ONDCP can step forward and join, Department of Justice, Veterans Administration, Department of Education, Department of Defense, never mind Health and Human Services, which will be at the center of all this. That we need more leadership, emergency leadership on the issue.
Thank you, General McCaffrey. We have some questions coming in from our participants. Karen writes in questions about, does the VA help with MAT after release from prisons or jails, or rehab support options? Can MAT be provided for vets by the VA while in jails? So, you know, and you mentioned some of the stigma that we're still tackling around medications for addiction treatment, Matt. So anything you could share with us, or share your thoughts about access to MAT for veterans?
Well, I'm not sure I'm current enough, but the quick answer is, particularly in the prison system, we made a major push over the years to try and get corrections. You know, pick a number, 4,000 some odd places of incarceration across the country, city, state, local, federal prisons. Pick a study you like. My gut instinct is 80% of the people behind bars, the actual cause of the problem was either mental health and or substance abuse. And so you have to, if you're in the correction system, you have to have reentry courts, that's resources, but also behind bars, you have to engage people, and that may include Matt. And then you have to turn people over to halfway houses and make sure they continue methadone treatment. Otherwise, they're back in jail. They're back on drugs within 5 days. They're back in jail within a year, and it costs you more money, Mr. Taxpayer. So doesn't this make policy sense to do that? And we've had great difficulty getting the corrections authorities. First of all, some of our correction authorities, they run a range. Some of them are spectacular. They're actually very well done, humane, knowledgeable people. I have a gender bias. I like to see women in charges of prisons. It changes the tone of the place. At one extreme is Rikers Island. That's a third world nightmare. You'll probably end up dead there or physically abused. They're now moving all the women out. So our correction system started to come apart along with a lot of other things in the society during the pandemic. We got to pay. That means you got to have higher recruiting standards, training standards, and monitorship of the people who are corrections officers. You don't end up with brutes behind bars. We don't do that very well. I think when I was doing, I went in and started going in to see governors and saying, in your state prison system, can't we? They're resistant to AA and NA behind bars. It's amazing. The best one I saw was a woman warden in Leavenworth, Kansas, and she had started by starting AA with life without parole prisoners. She said they're the illustrati of the prison system, and they have no hope of benefiting from conning the authorities. So she started with them. We need reform in criminal justice. I'm with a group called CCJ. Not playing a very useful role. It's hard for us to get together, hard for us to influence policy. But we know that is a major challenge. If you want to know where the end result of substance abuse is, it's behind bars.
Sort of picking up on that, and I'll get to a few other questions. We have so much data. We know that those re-entering communities from prison and jail are 129 times more likely to die upon release, mostly due to overdose risks than the general public. This is actually a Washington State study, your home state, General, by Ingrid Binswanger, I think it was. But we also know that providing medications for opioid use disorder, MOUD, reduces the risk of death by 75%. Like anytime we have like a life-threatening illness, that we have medications that can reduce fatality risk by 75%. I mean, every other patient group would just be, so focused on that, whether that was cancer or heart disease or other, if it was COVID, other illnesses that we're worried about when you have medications with decades of research around its efficacy and how important it is. And I really hope that all of our network here and the folks that are joining us, that if we can do a better job of telling the story of what the research tells us about medications, that we can tackle some of that stigma that goes hand in hand. I've heard that before, you're just moving from one drug to another. You're not really in recovery. All of these sort of, they're alive and they're well. We use medications for, so many other ailments and illnesses, and why not treating substance use disorder? So I think that's an area we have the research and the data. I think we, as the grassroots patient, family, practitioner community, when we come together to amplify that, I think we can make a big dent. So I have a question that came in from Aubrey about, she says, thank you for the conference. She is seeing more teens experiencing cannabis-induced psychosis and cannabis use disorder. Concerns about THC, concerns about CBD as well. She's a former Colorado mom who has sought refuge in Texas. So any comments about, we are hearing this as well, real concerns about as we change policies and anything about how we can get prevention messages and more to protect teens when it comes to marijuana use?
Well, teens and 40-year-old mothers. And I say that because, Washington State, Colorado, much of the country now is legalized either medical marijuana, which I think is worse than recreational marijuana, because it's medical. Why should you object to somebody under 21 partaking? And part of it's the edibles, of course, the edibles. And the 40-year-old mother, one of my older daughter's ICU nurse neighbors, the day the state of Washington legalized cannabis, her husband comes home and says, I got some marijuana fudge candies, and we're gonna try marijuana. And later on that night, the attractive 40-year-old was running down the street in this exclusive area, naked, screaming, chased by Seattle Fire Department personnel, wrapped up. And so that was, I don't know, was 8 or 9 years ago. Now she's stuck in a neighborhood where that's part of the recognition of what the legalization of drugs did. We've been trying to collect data through HIDA on the impact of cannabis use on adolescents, and they blocked an awful lot of this. Colorado is intelligently blocking tabulation of data on traffic accidents, which now exceeds marijuana-induced DWI is higher than alcohol. It's been an utter flipping disaster. And I think that's what's pushing up the drug use rates across the country. I don't have a clue what we do about this, until you got to replace stigma with the important people in your life, our pediatricians, ministers, homeroom teachers, the coach. Those are the important people in an adolescent's life, and they have to be willing to step forward and say, we love you, but on this lacrosse team, we're not smoking dope. And by the way, shave all your hair off. So we're just not doing it very well. People are embarrassed to talk against cannabis use. I did an interview in the Seattle Times. I said, I'll do one interview, that's it. With the op-ed board, editorial board, and they published my stuff without putting a slant on it, which to their credit. But from then on, I tell people, I'm not going to deal with your conference on drug abuse. Be the rented troglodyte that doesn't understand there's nothing wrong with driving stoned or operating on my eyeball stoned on Monday. Or it's been a huge thing. Our friend Jess, with smart approaches to marijuana, I'm very discouraged about it. I think, he's a brave, lonely voice, but basically we've lost it for a decade. And it's unfavorably impacting adolescents in particular. If you're 35 years old, living in a mountain in Oregon, growing 18 pot plants, knock yourself out. But when it comes to adolescents, I think we're going to pay the price, and we're not doing very well. Try and think of a time when your mayor, your county executive, your congressman has spoken publicly against marijuana use. Not happening.
Yeah, it's not a very popular position to take, and there's not, I think, not enough voices out there talking about that adolescent. I have, as you know, I'm a mom of 3 teenage boys, so it's of concern to me at the personal level, and I think that we need to bring the prevention conversation. Like, we can go upstream, and we should be focusing on how we prevent substance use disorders in the first place, whether that's for those really high at risk because of adverse childhood experiences or, addiction at home, or whether this is primary prevention of just making sure, like you said, General McCaffrey, those coaches, teachers, youth pastors, parents, mayors, like everyone has the programs, the content, the messaging to talk about preventing addiction in the first place.
I was thinking, for years I was on a board of directors of the CRC Health Group. It got sold. It was a wonderful organization countrywide. I think we had like 900 treatment centers, and we'd always have the clinic director speak at events that we'd hold to bring more attention to the treatment programs. I remember one 45-year-old clinic director in recovery, half of our clinic directors were talking about the first time she smoked marijuana was at age 5 at a big family dinner where her uncle gave her the pot, and it was of great amusement to the party going on. And so, what do you expect? One of my grandsons went to a graduation party after graduation from this exclusive high school. When he got there, the parents were really very professional and caring for the youngsters, and they had plenty of alcohol, pot, and tents set up in the backyard for consensual sex. And I thought, are you nuts? Do you realize that you're the parent, I don't know. So we got a failure of leadership in important institutions where it counts: small business, families, schools, never mind our political leadership.
A couple other questions that have come in. We had Ed Treat wrote in, again, sort of reinforcing this sort of need to prevent and talk about prevention before sort of people fall in that metaphorical river in the first place. We have a question from, we have some responses. Michelle wrote in and had lots of questions and thoughts about how do we improve our criminal justice response to addiction and mental health. Michelle, APF works closely with the Justice Community Opioid Innovation Network, which is a large NIH-funded study to really dig into how we improve outcomes for individuals with substance use disorders in the justice system, whether in community settings or behind the walls. We'd love to reach out with you and share some of the items that they're producing and that are available for our partners and practitioners on that. What other questions we have? Any other comments or questions, DA Blodgett or Judge Rancourt?
The only comment I would have, Jess, and again, thank you, General McCaffrey. Your points are so insightful, and being a retired judge and being in the criminal justice system for probably 40 years, and watching the history of this issue progress, a big part of, I think, what's going on in the criminal justice system has been education. Educating judges on addiction, what that means, what's a best resource to address people coming before the courts with addiction or substance use disorders and mental health issues. And one thing you raised, again, that is kind of a pet peeve of mine, General, is when they get into prison. And like you indicated, so many people have mental health issues that are going along with substance use disorders. And the prisons, many of them, will have you commit if you commit a disciplinary offense while you're in there, you're not subject to treatment, which is kind of counterproductive. And I always go back to the dynamic risk factors, like you're talking about reentry courts. And the risk factors, as you know, they're static factors. Your prior felony record, that's not going to change. However, the things that can change are employment, housing, in education. And those three factors clearly show that if you address those issues, the recidivism rates come down dramatically. And so when we're dumping people out of prison, and I hate to use that word, but they don't have housing, they have a felony conviction, they have no education beyond maybe 8th grade to high school, they're a candidate to go back in. There's no question about it. So that's part of the reform that I think is so necessary, that is being addressed, I think, now more than ever. But you raise such good points, and I thank you very much, General.
Judge Rancourt, remember Judge Pat Seitz, federal court in Miami?
Yes.
That's been part of her last 10 years' work, trying to push the notion of reentry courts. Obviously, it's expensive, but from a policy viewpoint, it's easy to make the argument that it's a lot cheaper to fund reentry courts and mandated treatment than it is to lock people. Rikers Island was running something like $50,000 a year. You know, it was like pushing Harvard or Seattle Pacific University for cost. So we do have a closed, broken cycle. Part of the challenge, as you know better than I, is there's been all sorts of hedges. A prosecutor's reluctant to back away from a violent offense. Frequently, that, I would argue, is still the best way to have somebody under judicial tether, but not behind bars and subject to mandatory supervision. We've got some dialogue to have politically. This administration ought to be open to it. Judge Garland ought to be open to it. So we have some work to do.
Jess?
Yes, Diabate?
So just real quickly, two points, and I know that Judge Rancourt would agree with me on this, the general mentioned. One always is resources. If we had more resources to deal with the co-occurring mental health disorders that goes hand in hand with substance use disorders, we can make more progress. And secondly, the narrative. It saddens me and it frustrates me that today the facts are second to the narrative. I still have people talking about how somebody's in a federal prison for having a bag of pot, and we all know that's not true. And the responsible prosecutors that I deal with every day all over the country, they join me and other responsible prosecutors in doing diversion programs, supporting drug courts. Two things that came out during this pandemic, which was so disheartening, and I've had these conversations with Jess almost daily, General, is our drug diversion program. I've had over 1,200 people go through drug diversion in lieu of prosecution since 2007, but when the pandemic hit, we had a tough time communicating with them because so many people didn't have cell phones and couldn't talk to the counselors that we've employed to deal with them. It's secondly, the loneliness you talked about. That's really a factor that should be discussed more, because without having the support, whether it's like you said, a coach, a family member, or whatever, people can further fall into that black space. But prosecutors throughout the country are certainly taking a chance, as I certainly was willing to do, and stick my neck out to work with somebody to give them the opportunity to get that help. And just use my own example, our drug diversion, 6 months minimum treatment at no cost. If you don't have insurance, it's not a disclaimer for you to be in there. 6 months. I've had people in my program 2 years. And if they trip and fall, which we know they do, if the clinicians that we've turned them over to say they can reboot the program, go at it. We want to do that because it's a great day for all of us when someone graduates. But I will still take the position that you've got to, just dismissing every criminal case doesn't work. There has to have that, you have to have the ability to say, we're going to give you the chance not to go through the system. But if somebody is going to continue to be selling drugs to the neighborhood kids, there has to be consequences. So that's always the balance. And we try to be smart about this and do it. And then secondly, we need more focus on kids who come from families suffering substance use disorders. That's just a passion of mine at this point in my career. So many kids are unseen and unheard because they're coming from such difficult family situations. We'll talk about that later today and what we think some of the solutions are. But you have to have accountability. I call my program compassion with accountability to make it work. It's not easy. It's not a tried and true formula, but the narrative out there that we have right now is disturbing. We need more factual accuracy and reporting on how this is being done so that we can all get the resources that we additionally need to keep moving forward with our program. So thank you, General. You hit on so many points today that are so accurate, but we continue to fight the fight.
Yeah, boy, you've sure been a leader in this area, John. Thank you. Those remarks.
I have one other question that came in from Michael, and I'd love to, I think this is important to raise. He commented, do you think America's failure to still openly recognize stimulant use disorder as an equivalent disorder and also part of the public health crisis hampering the current efforts to quell the onslaught of OUD? We saw sort of record amounts of fatalities and lots of increases all over the country with stimulant use disorder, both cocaine and methamphetamine. We don't have medications yet to treat stimulant use disorder, but we do have tools in the toolbox to treat meth and cocaine addiction that are underutilized. So just comments from our panel on how we do a better job of really raising this issue up and sounding the alarm.
Yeah, I tell you, the methamphetamine in particular has always scared me half to death. That there is a disaster drug. It's that menace. You can make it in your backyard, although now I think 95% of it's coming out of Mexico. High quality bulk production, almost impossible given its low visibility to most of our sensor systems. Gets into the country. All of you have seen. Many of you deal directly with methamphetamine abuse. Just amazing to me. I tell them some of the Midwestern states, it's single white females who were the principal people facing consequences. So when you got this nice looking young mother, 2 kids, she's working 3 jobs, and then she discovers methamphetamine and their fatigue goes away and everything's looking a lot better. And then 1 year later, it's done permanent organic damage to the brain function. And she's down 100 pounds and she's turning tricks in the street. Teeth are rotten. It's the most destructive single thing in the world to see. The prevention programs, I think, have to be sub-optimized to deal with that drug. So it's public education rather than prevention. To play back the consequence, we had a billionaire just help us in, I think it was Montana, and he spent a ton of money focusing on adolescents and meth. And we were getting 14-year-old kids that were shooting a police officer right in the face when stopped for a traffic offense. Stimulant abuse will roar back, as most of you know. I tell people, we don't care what drug you're using. It's really almost irrelevant. It's a destruction of human life, spirituality, personal health, the work environment, the byproduct of all these. And John made the major point, mental health. Mental health and substance abuse are just 2 sides of the same coin. And I think we probably have a bigger challenge with mental health in some ways than drug treatment programs.
Thank you, General McCaffrey. One of the things that we're working on the APF side is that as our communities are struggling with stimulant use disorder, we know that contingency management is very effective, yet there's lots of barriers to the uptake where you can, what I love about contingency management are using incentives and you're using that reward center of the brain that's compromised by addiction in the treatment of addiction, which is genius. And we have also decades of research that this works. There's some barriers to using federal funds for treating stimulant use disorder with contingency management. There's some new digital therapeutics that use contingency management that are really exciting. So I think if we keep talking about this and give it visibility, we've heard from some of our patients who are struggling and families who have a loved one struggling with stimulant use disorder. There's so much focus on opioids, and there can sort of be a feeling of less than, that this is sort of the overlooked epidemic that's happening nationwide. And I think there's more stigma with methamphetamine, crystal meth, cocaine use than there is other substances, whether that's alcohol or opioids or marijuana. So that's something that going into this next year, APF is really going to be focused on to make sure that all patients struggling and in need of treatment and support have equity here and are seen and heard. So that's a big priority for us. I know we're going to keep a tally of all these amazing questions and comments that are coming in. And we will respond with resources that we have or connect you with some of our other partners if we don't have the answers to these questions. I apologize that we can't get to all of the great comments that are coming in for each of our speakers, but we're really grateful that everyone is so engaged. And we're talking like 2-paragraph questions and comments here that are so rich and well-informed and thoughtful. I'm really grateful to everyone for their time. General McCaffrey, I know that you have to depart soon for another event, but any sort of, remarks or sort of final words to kind of sum up your session today. And again, we're so grateful that you took time to help us kick off our event. Your input and sort of perspective on what's happening throughout the country is always really helpful for us when we get our network together.
Yeah. Well, Jess, let me just say thanks to you for your leadership, for keeping our community together of people that care about the issue and stayed with it over the years. It's vitally important. APF, I think, is one of the preeminent groups in the country that's doing this. Do not falter for us. We need your leadership. Okay, good luck to the rest of you on your important work.
We appreciate it so much. We won't falter. We're going to keep at it as always and make sure that we follow the science and keep our network together. And we're so grateful to all of your leadership.